Well, there's nothing like just in time. It's 9 o'clock and I'm just on the call, but welcome to this week's Crisis Jam. And Brian, did you watch the space launch last week when
Yes, I did.
Jeff and his brother and Wally Funk and a young man in 10 minutes went 60 miles above the earth and came back. And before they did that, I think I would have assumed this kind of interstellar sort of space stations and travel to Mars and such, and the moon as a common occurrence was fanciful. And yet they're going to reuse that rocket over and over again, like a Disney ride, to travel up and look at the Earth and come back down. And Brian, do you know by chance their motto?
No, I don't.
So that's our quote for today. Karen, if we can go to the next slide. So on the launch pad, they have this phrase, and I don't speak Latin, but gradatum ferociter, and it means step by step, ferociously. So they are moving step by step, and their first step was to be able to take people up 60 miles above the earth and come back down. Their next step is to go round and round the earth, and their third step will be to go to the moon, and then they'll keep going past that. But I think when we think of mobile crisis available to go out to where people are in every community of the country, and facilities that people can get directly into, and 988 that answers the calls for everyone who has a mental health or substance use or addiction crisis, or suicidal crisis, I think we think of that a little bit as the space station. And yet the way that we get there is step by step, ferociously. And Brian, we've been using the phrase gentle pressure relentlessly applied, but we're officially going to vacate that. The new phrases are post-COVID strategy and step by step, ferociously, because it speaks a little bit more to the actions that we need to take. Wherever we are, we just keep putting components in place. So and that's what we've been doing week over week and month over month as we've prepared into this. So let's go to the next slide, Karen. Margie Balfour, are you with us this week for the July 28th Margie's Crisis Meeting? Margie, are you with us by chance?
Looks like I just joined at exactly the right minute.
Margie, just in time is perfect. Tell us a little bit about the young man with the coffee cup.
Oh yes, this one is, we've got this whole system where you expect a certain amount of response and service and payment and, just a systemic response for a health emergency that doesn't have a psychiatric diagnosis attached to it. And so, the challenge is that a behavioral health crisis, it's a, potentially fatal health emergency, just like anything else, and therefore should have the same expectation of a response. Change my mind then.
I'm right there with you, Margie. Thanks so much. Hey, Margie, do you have the pipeline is fully exhausted?
I have another one I'll send you.
Okay, so let's keep the pressure on. Margie's doing these great crisis memes, and we want one every week, Margie. That's all we want.
Okay.
Okay. Let's see if I know Richard and Anita are both in the National Academy of Sciences I think all morning long sessions on suicide prevention and crisis services. John Palmieri, is there anyone from SAMHSA to give an update?
Hi, David. Yeah, it's John here. How are you?
Oh, hey, thanks, John.
So yeah, just very quickly, the rest of the team is off at other meetings. We are very deep in the FY23 appropriations process, so doing a lot of work preparing for reports related to that. Also really working hard on communications, really recognizing that obviously there is a need to get some additional messaging out, particularly with carriers moving forward with 988 implementation, and making sure that we have key messaging and talking points for the community, providers, and the public to make sure that there's clarity around what's available now and what really should be used currently to support crisis services. A lot of work, both in terms of convening internally within the federal government through the Interdepartmental Planning Council, as well as the Behavioral Health Coordinating Committee, which Richard is actively involved on. And they're really trying to align with our federal partners around a number of areas where we think there could be positive impact on 988, including coordination with 911 and emergency medical services as one example. So a lot of work on that front. And then also very aware of all the excellent work that's happening in the communities related to convening stakeholders, surveying, assessments that are going on to track state level activity with respect to planning for 988 implementation. And that's something that we really are trying to get a handle on. There's multiple data points there, planning for some broader convenings to really understand the data, to synthesize that, and really to hopefully inform some solutions that SAMHSA can be a part of. So that's it for now.
Great stuff, John. Hey, John, is there any update on the infamous SAMHSA reporting that will be coming out about all of the 988 and next steps?
Yeah, they are they're actually finally out of my hands, which I'm happy to report. Maybe not forever, but for the moment they are. And so they're in the internal review process. And so, that will take some time, but I think our target is certainly to get them out by late summer at the latest. And so hopefully through the clearance process, that is still realistic.
Terrific. Thank you, John. Brian, update from the states.
Yeah, thank you, David, and thank you, John and SAMHSA. We had a call with Sherry Dawson of Nebraska this morning. And, we're talking about post-COVID strategies, but also we were talking about the events from yesterday. There was a hearing yesterday, and there was testimony given by the officers from the January event, the attack on the Capitol building. And what they were talking about were that they still had symptoms of post-traumatic stress disorder. And they were referring fellow officers to get help. Right. And where they could go to get help. It was a very emotional hearing, mostly because of the testimony from these officers. The second issue that we were talking about was related to Simone Biles. And here you have the greatest of all time, gymnast who has shown her strength over and over and over again, physically and mentally, who basically pulled out of the event that she was scheduled for and said that she just wasn't right in terms of emotional, mental well-being. And some of the pushback on that was that she should have been tough enough to move ahead. And of course, if she had had a muscle pull, no one would have said too much about it. Yeah. But this, for some people, is a sign of weakness. So Sonia Gaines, the commissioner from Texas, on LinkedIn this morning, she put on a quote from Simone Biles. And I wanted to share it because I think it fits so much of what we're trying to do. And her quote is, "Put mental health first, because if you don't, you're not going to enjoy your sport. You're not going to succeed as much as you want. It's okay sometimes to even sit out big competitions to focus on yourself, because it shows how strong a competitor and person that you really are, rather than just battling through it." And for people who aren't up on this, go in and take a look at the video of her vault and compare it to the way she usually performs. That vault was scary. Yeah. She could have easily severely hurt herself. So taking herself out and saying, I have to do better emotionally, I have to get my head together, I have to have mental health, was really a step forward for the field. And I think it fits so well into what we're all trying to achieve. But I wanted to let you know that in addition to post-COVID strategies, the commissioners are really paying attention to what's happening every day in our country. And this seems to be a very special moment when it comes to mental health. And we're really looking with the commissioners at how we can build on this moment. Those are the words I wanted to talk about, but also I asked Megan if she would say a few words, not related to this, but related to a different topic. So I didn't know if you wanted to respond to that and then go to Megan.
Yeah, so just a quick comment, Brian. This is so inspiring. And while some of the, I finally saw some of the predictable pushback of not brave enough or whatever this morning. In general, the comments overall from the media have been much more positive than I would have ever expected in the past. So that seems like a breakthrough. And she's an amazing person. And these comment about law enforcement, Brian, every time we talk to law enforcement about crisis, one of the first things that comes up is our own officers are frequently in crisis. So this is terrific comments. Megan, we had a great meeting with Steve, right? But your comments may be on something else, Megan.
They are, but I really want to thank you for that meeting, David. We're very excited to move forward with Steve Hammerdinger, and thank you for your engagement on deaf and hard of hearing issues. Really appreciate it, and
we'll
look forward to next steps.
And we'll have him as a featured presentation coming up in about 6 weeks.
Great, fantastic. The thing I wanted to talk about today is, as we really establish crisis services as we are, and the momentum is so strong, we also asked the question at NASHBID, and the field is asking the same. What keeps people out of crisis? How do you stabilize somebody in the community post-crisis? And really supported employment and supportive housing are those pillars that really do that. We've been focusing on supported employment in particular. And as we have been doing that, we also ask, well, what historically supported employment has been seen as adjunct. And we see it as essential to mental health recovery, as well as substance use recovery. And so we're looking at what policies are barriers, what relationships between mental health and vocational rehabilitation need to be stronger. We really encourage those relationships even outside of that with the Medicaid agency, but also supported employment as a continuum. Rather than waiting until somebody is so disabled or so down the line, how can we intervene earlier, much the way the field is going anyway, so in a wonderful way. So that's what I wanted to talk about, is kind of rethinking supported employment and that essential service.
Terrific, Megan. And Megan, those kinds of comments about pre and post supports to crisis have been common. I think at times we have not spent enough time on that, primarily because of trying to build these key infrastructure. But let's talk together about having some featured presentations on some of those topics as we move into this coming year.
Great. Thank you.
Thank you, Megan. Karen. So if we talked about step by step, ferociously, there was a time we had about a dozen states, Office of Behavioral Health involvement in this weekly learning community. Today, we essentially have all 50 states engaged, but we have about 10 states that we know of that have Medicaid representation at the table. So we've stalled a little bit at those 10. So I'd encourage you, again, if you're on this call already from a state that's not in blue and you're with the Medicaid authority, then please let us know and we'll highlight that on here. But if you're a state that doesn't yet have a partnership with Medicaid in this learning community, then please let us know, connect us, introduce us. Let's see if we can't take step by step and turn some more of those states blue. And again, if you're a national organization, please let us know. The other thing is we were really growing at a pretty solid clip, and we have not broken this record of 272 yet. So we're really pushing to break through 300. So help us out, invite some more folks to join, and Karen Jones on our team will help you get them into the invite. The other thing that we're hoping to do in the coming weeks is take off this Outlook invite and schedule this through a more professional sort of means that doesn't barrage you with invitations. So we're working on that, so stay tuned. Karen? And again, the videos, the transcripts, and all the tools that we talk about are on the Crisis Talk website. Stephanie is, if you were on the very beginning of the call, Stephanie is not able to be with us today, but we had this terrific opportunity to meet Dr. Eric Raflawan, who was actually after his New England Journal of Medicine article, we outreached him and he was on the Crisis Jam that coming, I think the next day or the day after. But Eric, are you with us today to talk a little bit about the article and the interview with Stephanie?
I am. I'm here by phone. Can you all hear me okay?
Excellent.
Okay. Yeah. So unfortunate that Stephanie's out sick today, but it was a pleasure to work with her in the article, and she really did a wonderful job highlighting the history of the Black community in Pittsburgh and their contributions to the EMS services that we now enjoy nationwide. So I really encourage everyone to, oh, sorry, go ahead.
Yeah, clearly we want people to read the article, but say just a little bit more because this is a really amazing story.
Yeah, so a couple of key points. So one, it provides a really good historic overview of how the EMS system was, or the model for EMTs that were used by EMS nationwide were developed by a Black community in Pittsburgh that was struggling with racism and neglect from the city and the first responders in their community. A couple other things that I think are really well highlighted in the article are the need to look beyond the current services that we have now in clinical crisis response, mobile crisis response, and looking at the skill set of what we need rather than trying to pigeonhole current professions. And that was something that they did in the Freedom House model. They basically developed the EMT standardization that we now expect nationwide. And then one other last thing, which I think is really important to highlight, is that part of what drove this change and this progress was the racism. And so as we look to develop equitable systems, we have to realize that the infrastructure that these systems are situated in are really structurally disadvantaging certain groups, and to be really cognizant of that and actively anti-racist in the way that we implement things. And so just a quick example of that would be looking at, so now that if we shift to mobile crisis versus police, who gets the mobile crisis versus who gets the police? How is dangerousness defined? Do certain people go to certain areas? Certain responders go to certain areas over others? And so there's going to be a lot of kind of more gritty details as these things get rolled out.
The disaggregating of the data is really the key, it sounds like. So tremendous story. And we've had Rebecca Newstetter on this Crisis Jam before, and seeing the role of race and equity, or racism, or attending to specific needs. These issues have threads not only with EMS, but 911. The last thing, Eric, Stephanie was really proud of getting access to these original photos. Were you involved with that at all?
I wasn't. So I have a colleague who work at the archives in Pittsburgh and at Harvard, so I connected her with them, but I didn't have access to the photos myself. But there are some great historic photos there.
Well, terrific. And we're looking forward to having you as a featured presenter next week.
Yes, looking forward to it.
Awesome. Tanja Miles, are you with us today? Give Tanja a second. Tanja may not be on today. Again, if you want to check out Tanja's story, she's been a regular contributor on the Crisis Jam. The website is Moving America's Soul on suicidefilm.com and mesosfilm.com. Karen, next slide. Sarah Corcoran, are you with us for an update? Every time I think it was millions and then it was billions, and I think today the amount is trillion. Am I on the right path, Sarah?
Well, yes, it's definitely an uptick in activity, although I, am warning everybody, I won't have as much to report potentially in August, because traditionally everybody leaves DC, including the members of Congress. Right. But at the end of this week, the House will begin their recess, And next week, the Senate is expected to head out as well. A little bit of breaking news on the bipartisan infrastructure framework, also known as BIF, something I'm still not used to saying, that they seem to have reached a resolution on that and will be voting procedurally to move forward. We still don't have any text of what that package should look like, but it's around the $500–600 billion level. And we are looking out for the next week to see if there's a budget resolution document coming out of the Senate on that $3.5 trillion package that will include more of the human infrastructure rather than the bipartisan physical infrastructure package. And then the final update that I've got today is the House FY22 minibus, which is a package of 7 of those different appropriations bills, including that labor HHS education one that we've been reporting on over the past couple weeks. They're working on and finishing up that amendment process where there were 700 something amendments submitted, 229 were forwarded for consideration in the House floor. I looked through them, not a whole lot of monumental things, although we'll keep you posted when we learn a little bit more on if any of those will have an effect on things. But that final vote is teed up for later in the week before the House heads out for their recess. And those 7 bills, I believe there should be 13 overall. So they're getting a decent amount done before the August recess, but there's still no action that we are aware of on the Senate side coming up to that September 30th deadline for the new fiscal year beginning on October 1st. But we'll keep you posted as we learn more, although popular wisdom is we're expecting at least some sort of short-term continuing resolution, given the amount of work that will have to get done between when the House and Senate are back in September, mid-September, before the end of the year deadline.
Great, Sarah. And Sarah, these updates have been so important. So during this quote unquote downtime, let's think through whether or not to take those weeks off or rather to use those for some other strategic purpose where you prime us on process. So let's think through what would be the best use of that.
Sounds great. I mean, I know we all are budget resolution experts given what we were talking about earlier in the year, but it's always fun to have some wonky trivia, party trivia to bring up when you're talking about congressional procedure. So it'll be the hits of all of your holiday parties later in the year.
So Sarah, I think Margie's crisis memes and Sarah's wonky policy trivia is it may be a thing for August. So great. Taylor, Natalie, are you guys with us from AFSP? Anything that you would add to this discussion on what AFSP is tracking and prioritizing?
Yeah, sure, absolutely. And I would love to join Sarah's wonky trivia for sure. So I just wanted to note that next week there's a markup in the Senate Help Committee on Tuesday. They haven't announced the time yet, but they're going to be marking up the National Suicide Hotline Improvement Act. It's S2425. I'll go ahead and put it in the chat as well.
Right.
It's almost identical to the House passed version, except for they've changed the authorization in the bill to the $113.6 million House passed, or hopefully soon to be House passed funding level from that $50 million number that passed out of the House back in March. And so Senators Reid and Moran introduced the bill late last week pretty quickly.
Terrific, Natalie. Anything, Taylor, are you with us by chance?
Taylor's on vacation actually, so it's just me today.
Okay, great. Thank you so much, Natalie. Yeah, any update on Connor? Is he missing us?
I haven't talked to him in a couple weeks, so I think he's just getting ready for law school and is enjoying his summer.
Oh, great.
See you guys.
Oh, Connor is with us. Okay, Connor. Well, look, we want you to jump in here as you have opportunity. Connor, when do you get started? Okay, that's all we're getting from Connor. Hey, Laura Evans, are you with us?
Oh, he's here.
Laura, are you with us today? Angela Kimball, do you happen to be with us today? So we'll pass on the map section for today and keep going. Tom Betlock, I know you're with us for the calculator update. And Tom, you and I were talking about how best to use this time today. And there's a resource that you wanted to highlight for everyone.
Yeah, David, I think it fits in with your theme of step by step ferociously. We've talked over the last several calls about some of the funding opportunities that are out there. And, I think the next step then is for states to be thinking about what implementation looks like. And we've compiled a resource that includes a lot of different things. So, when I was back at the state, I fully encouraged our staff to plagiarize, take the best of what's out there from other resources. And so, we've got a compendium of resources. It's about 23 pages long that we're going to put up on a website, and we'll get folks out the link for that. But it includes from Arizona the MCO contract language in terms of the requirements around establishing the Crisis Now model. Again, in Arizona, it's a braided funding system. So it's not just Medicaid. There's a variety of different funding streams that go to support that. There's information on there in terms of billing guidance. So which codes to use for which services. And then also Arizona has published rates on those different codes. There's information on how this is funded for the managed care contractors through their capitation rates. That's part of what's included in this compendium of resources. There's FAQs that were developed by Arizona staff to sort of lay out how the crisis system works within the managed care model for the state of Arizona. And then there's licensure information in terms of licensure around the stabilization facilities that's used as well. So it's 23 pages. It's a great resource. And as states think about moving and leveraging all of these new dollars that are out there and wanting to think about that from a system design perspective, having this as a resource, I think is helpful. We'll get it up on a website, we'll get a link, and we'll push it out, David. But I think it fits well with the step-by-step ferociously as we start moving from here's the grant sources that we have, let's move to implementation.
Tom, what are you hearing about the Medicaid mobile crisis planning grants? Are folks moving on this?
David, I'll have an update for you next time. Those applications, we highlighted that last time in terms of what the due date are. The letter of intent was due, I believe, in the last couple of days, and then the application is due in mid-August. So I'll circle back to NAMD, and we'll be pushing information out to states as a reminder.
Wonderful. And any other, so we highlighted Indiana on that home and community-based services initiative. Have any other states caught your eye, Tom, since we talked last on that topic?
I have seen nothing else to worth highlighting at this point in time, David.
Okay, great. We got just a minute before we start our feature presentation, and thanks so much, Tom. Dr. Mike Hogan is making some comments in the text that I thought were worth. Mike, do you want to just reference going back to Megan's comments about supported employment, supported housing?
Yeah, just very, very quickly. I mean, I've worked on this for a very long time, and the supported employment just still doesn't get enough play. A little bit of that is because the complexity of financing it, where there are major parts of it that Medicaid can reimburse and parts of it that it can't. The purely employment related parts can't be conventionally reimbursed by Medicaid. So you need to braid funding, which is easy to say, but very hard to do. But I think a bigger part of it is that employment hasn't really been seen as a core mental health treatment function. And, that meds and therapy and case management and so on, none of which, by the way, show in the research literature any impact on employment. But paradoxically, employment and the research on individual placement and support shows this, employment reduces hospitalization. And so the evidence on that is very strong. And so I just noted that. And also the related thought that the prejudice we've had often is that people had to be ready before they were referred for employment, because they, it came before, in a sense, treatment comes before recovery. It turns out to be the other way around, that work often is the cause of recovery, not the result of it. And so anyway, just a couple of comments to reinforce Megan's important point.
Great, so much. Thanks so much, Mike. Great stuff. Karen, let's go to our featured presentation. And look, every week we've tried to highlight great work that's already being done, pushing into coordination with emergency medical response, with law enforcement, with 911. And Chuck and Golia and the National Council team brought us attention to the work in Austin. So we had a Crisis Talk article on this, but excited to have, I believe, Marisa, are you with us today to tell us about the work that you've been doing at the CCBHC in Texas?
Yes, I am.
Welcome.
Thank you for having me today. I'm very excited to let you all know about our program at Integral Care. Integral Care is the local mental health authority and local intellectual and developmental disability authority of Travis County, which is in Austin, Texas. We're also, as David mentioned, a certified community behavioral health center. We have a pretty robust crisis system within our agency. Our agency has a 24/7 crisis helpline, 2 mobile crisis outreach teams, a urgent walk-in psychiatric emergency clinic, and then we have a few crisis residential and respite facilities that our MCOT teams can facilitate admissions to, as well as an extended observation unit. What I'll focus the presentation today is on our MCOT teams. Our original MCOT team started in 2006, and they receive all of their referrals from a 24/7 crisis helpline. Our expanded mobile crisis outreach team started in 2013, and they provide the same service provision as the other MCOT team. The only difference between the 2 teams is the way in which they're deployed out into the community and the referral sources that we have. The expanded mobile crisis outreach team was really built to ensure that we were capturing referrals that weren't going to our 24/7 crisis helpline, and we're getting just basically referred to from 911. So first responders were provided with the ability to call and request an MCOT clinician on site where that crisis was happening in real time to start that clinical assessment from someone that was experiencing a mental health crisis. The goals for the MCOT teams are really to remove barriers for individuals that were experiencing challenges, whether that be financial, transportation, or lack of family support to help them navigate connection to services. We collaborate with several key partners within our community, whether that be school districts, first responder partners, paramedic systems, and criminal justice systems. We provide training to first responders. All of our services are community-based so that we can ensure that we are meeting individuals where they're at, reducing barriers to accessing services. And our goal is really to prevent the overuse and misuse of very restrictive settings for individuals. So the overuse and misuse of emergency departments, inpatient psychiatric hospitalizations, and incarceration so that individuals receive the right care at the right time. Following our initial assessment, we are able to provide community-based services for up to 90 days. In those 90 days, we have case management, living skills training, and a mobile medical provider that goes out with us into the community to provide medication evaluation and stabilization to help support the individual in their most appropriate level of care and reducing any unnecessary higher level of care for that individual if it's not needed. Next slide, please.
So Marisa, just a quick question, and you may get to this, but when you talked about that direct access for law enforcement and 911 to engage mobile, how did you operationalize that? Is that a distinct number that comes into your team? How does that work?
Yeah, so what we did was we provided communications, our 911 communication system with the partnerships that we have with a number that they call us. Essentially what it is we're kind of on an old-fashioned system where they call a number and it connects directly to a pager that the team has on them. So once our team receives that page from the first responder system that is calling, and that could be our sheriff's department, our police department, or EMS, they are situated in several different spots within our county for rapid response. They determine internally who is the closest clinician or in their service array. And then they call communications back to provide an ETA so that dispatch could then notify the officer or medic on scene of our arrival time. With PD, that's what we're doing through the communication center. However, our EMS partners have provided us with radios, and we're able as healthcare providers to get on their channels and provide ETAs in that way, which is really awesome, and it helps with efficient communication.
Great, great.
All right, so here's a little bit about the timeline. Again, our expanded mobile crisis outreach team, which I will focus the rest of this presentation on, started in 2013. It was an 1115 Medicaid waiver project that included 21 full-time employees. Our classic MCOT team, which we call internally, that is deployed out through our helpline, is still in existence today. In FY 2019, our funding shifted to local entities due to requirements from the federal waiver. And so Travis County and the city of Austin assumed funding for our program. In fiscal year 2020, the city of Austin further expanded our services to provide 28.5 full-time employees. The reason being is really looking at how do we increase opportunities to provide diversion efforts more upstream in the crisis continuum. So one of the service arrays that we added was telehealth services, where we disseminated iPads to our first responder partners. With EMS, it was our community health paramedics, and with Austin Police Department, where they had the ability to determine on site with someone that they were experiencing a mental health crisis, and they could start a telehealth service immediately through very much like a FaceTime to help with a more direct and immediate connection for crisis screening for the individual in crisis, but to also reduce first responder time on scene and their ability to be released so that they were able to be responsive to areas of their expertise that included public safety and medical emergency. The second one was to integrate EMCOT clinicians, so the team that's been receiving referrals from first responders, into the 911 Emergency Communication Center. In FY21, so this current fiscal year, we received additional funding to expand upon the services that we started in FY20. So we are integrated now at the 911 call center. We've reduced our staffing patterns to 41 full-time employees. This includes clinicians in the 911 call center as well as field response clinicians. And we have the availability to be 24/7 now at the 911 call center. Next slide, please. So prior to our integration into the 911 call center, what it looked like was first responders were deployed out from the 911 communication center. They arrived on scene, determined it was a mental health crisis, and then got on their radios to request EMCOT assistance on site. When we arrived on scene, our goal was within the first 10 to 15 minutes, in the absence of a public safety issue or a medical emergency, we would release the first responder back out into the community, again, so that they were available for their area of expertise, and we could stay with the individual to provide our clinical assessment, safety planning, and facilitate follow-up services or admission to a higher level of care if needed. Where we're at today, very exciting, is with the integration into the 911 call center. We have the ability to have calls transferred over to our clinicians when the call takers determine that there's not a public safety issue or a medical emergency. Our clinicians take over that call and we determine what is the best resource for that individual. We have the ability to provide emotional support. We also have the ability to see if the person that we're talking to is already connected with our services. We can link them back to their ongoing treatment team. We have the ability to provide crisis de-escalation resources and then call them back at a later time to just ensure they are still remaining safe in the community. Or we can send out our own team to provide a face-to-face clinical response in the community instead of sending police out. There have been several iterations of this project since we started. It has been very successful, and we've added a bunch of components to ensure that we're really meeting the needs of the community for the calls that are transferred over. Next slide, please. Some of the calls that call types that are appropriate for transferred over to our clinicians who are co-located at the 911 call center are individuals that are experiencing a non-emergency mental health crisis. There's no evidence of active or imminent violence to that person or someone in the community. Non-violent disturbances or disputes specifically related to mental health crisis. Mental health crisis involving youth and non-mental health parenting issues, and any calls that may benefit from de-escalation efforts prior to the first responders' arrival. Next slide, please. Calls that are ineligible for transfer to C3, and C3 stands for call center clinician. That's what our clinicians are called at the 911 call center. Are calls where there's violent behavior towards self or others, physical possession of weapons, so firearms, knives, etc. If there are weapons in the home, that does not necessarily exclude a transfer to our clinicians. The call takers are trained to determine if there's any type of imminent risk of harm with a weapon during the call that they're screening. A commission of a violent crime, for example, family violence, severe intoxication, poison or injury, or imminent risk of harm for the individual hurting or killing themselves or other people. Next slide, please. So as I stated earlier, there have been several evolutions of where we started, and we integrated into the 911 call center on December 16th of 2019. At that time, we had one clinician on the floor, and they were providing 40 hours of availability for 911 Austin Police Department call takers. We started with a very narrow focus of call types that we were able to receive, just so that not only our clinicians, but the 911 call takers had felt comfortable and confident about the transfer process and what calls were specifically appropriate for us to take over. I'd also just like to point out that when we started this project, we were not directly connected into the technology of the 911 call center. So call takers were transferring over phone calls that they determined were appropriate to an administrative line that was at our cubicle. What we found during implementation was that we had a lot of dropped calls for that transfer process to go over to an admin line. Yeah. So in June of 2020, we were able to get integrated into their technology systems where we are now in SoloCom. We have modified access to their CAD system, computer aided dispatch. where we now have the ability to not only view, but write in their CAD system any call notes that would be appropriate for first responders to receive if we have to transfer the call back to police because there's an imminent risk of harm to somebody. And we added call types specifically related to if someone called into our call center and they were requesting a mental health officer, if there was not an identified public safety issue, those calls would get directly transferred over to our clinicians. The following month, we added a check welfare call type for individuals that were second party callers. And
So Marisa, just a quick question. This is tremendous integration, but it also speaks to kind of risk management and legal issues of you documenting in their record. How did you address that together? Do you have some kind of MOU, or is there more legal document that speaks to how you address those issues cooperatively?
Yes, that's a great question, especially since we're communicating through their CAD system. So before all of our clinicians are going into the call center, they have to go through CJIS training. So they're all CJIS level 4 trained, so criminal justice information systems, to even be allowed onto the 911 call center floor and have and view access to the CAD system.
Right.
We also have an MOU and an interlocal with the city of Austin, and then specifically an MOU for this project.
Right.
For us to kind of move forward through communications and things of that nature. We have put our clinicians through an enhanced CAD training that gave them the ability to document and communicate with the call takers and dispatchers through the CAD system. And then just internally, because we're bound by HIPAA, we had our legal counsel review certain words and phrases that we would put into the CAD system and approve those before we started communicating. If there's imminent risk of harm, we have the ability to communicate more freely in the CAD system on the police side.
Yeah.
However, if there's, and I'll talk about the other call types that have been added, but if we are determining that someone's not at imminent risk and we have to transfer back to police because the person is requesting it, we're limited in what we can put back to CAD.
Makes sense.
It has to be very general. So all of those statements have been approved by our general counsel to make sure we're within the parameters of HIPAA.
Terrific.
All right. In October of the same year, we added a clinician to be available to the EMS call takers. Our call center is a combined call center where we have our sheriff's department, our police department, EMS and fire all on the same floor. They're just in different sections within the communications floor. And the way in which calls get routed are APD call takers are the initial point of contact. So if someone says EMS or fire, they are still on the line and they do the initial transfer over. So that's kind of how our call center works. When we're with EMS, because they're a healthcare provider, we have more ability to talk more freely in their CAD system.
Right.
And their CAD system is separate from the police CAD system as well. We are not diverting ambulance response from the call takers right now. However, that is something that we're looking forward to in the future. Our purpose for the EMS call takers is really to help with de-escalation and utilizing our internal electronic health record to support providing information to EMS prior to their arrival on site with someone.
Marisa, all of these steps seem important. If we talk about step by step, but some of them have a nexus higher valence. This February 2021 seems like a huge breakthrough.
It is a huge breakthrough. What I've been told is that we are the first city in the nation to add mental health service option when you call 911. So in February of this year, we added to our call script, Austin 911, are you calling for police, fire, EMS, or mental health services? This really, it was a game changer. It gave people an opportunity to self-identify there was a mental health component when they called 911. Not all of the calls that are mental health component are able to get routed to us. Some of them have a safety component that would make it inappropriate. However, we've added layers of support in those instances so that there is an appropriate mental health response. We have the availability now to be conferenced in on what police call hotshot calls. So it would be a mental health high priority call. Maybe there's a weapon involved. It could be a barricaded individual where we're conferenced in providing consultative services, or we take over the call with the call taker still online while police are en route. We have the ability now to have calls go into a call queue for our team. So even though we're 24/7, we don't have the staffing capacity to handle all of the calls that are coming in designated as mental health appropriate for our team. At peak periods, we could have up to three clinicians, but at the very baseline, it's just one clinician available to take these calls. So if there's no imminent risk of harm, and the person is willing to wait for a counselor, that goes into a call queue. And then when our clinician's available, they'll go into that call queue and start calling people back.
So Marisa, just so I understand, you've built a really core 24/7 coverage, but it is minimal. And you could, and all the infrastructure is there, but you do need more resources to adequately supply it.
Correct, yeah. We have about 15 clinicians that are designated for this project. However, the volume of calls that are coming in, we don't have the staffing patterns to support our being able to take care of all of the calls that don't have a public safety issue. A really cool thing that we have been added that the officers are really excited about because of these capacity issues that we're having. If the call is routed to them and they identify looking through the CAD system, or they may know that this individual that they've responded to before, there's not a public safety issue, I know this individual is safe, they can now transfer it back to our team in the call center and ask that we try and engage and make attempts to call that person to divert their response if appropriate. So that kind of goes back to your earlier question of if we're trying to make contact with the individual and either they don't answer the phone or we've offered our services and they're still requesting police, we have to assign it back to police, but we can't tell them why. We can't give specifics other than there's no imminent safety concerns.
Marisa, I'm not sure how many slides you have left. If we could wrap this up in about a minute or two, I'd love to get some comments. Chuck Ngoli was the one who referred us to you guys. But any final wrap up sort of thoughts, Marisa?
No, I think the next couple of slides are just data specific. We can go, I think we did a lot of that already. We can go to the next slide so you can see some of the data. Like I said, it was a slow rollout just due to capacity and staffing. To date, from inception of the project to where we're at June 30th, we've had 2,166 calls. The calls that we've been able to divert from police response is 82%, which is really great. I would say that of the calls that we're not able to divert, about half of them are related to imminent risk of harm, and the other half are because people are still requesting police response even after we've offered our services. This just shows a breakdown of our outcomes. So you can see that only 23% of the time is our team actually going out to do a face-to-face response instead of sending police. The majority of the calls that we're taking, we're able to provide emotional support, resources, and/or connection back to their ongoing treatment team. PES, just so y'all are familiar with that acronym, that is that we refer to our urgent care walk-in clinic with our agency. So that's all the information I have, and I'm certainly open to any questions that anybody has.
So Marisa, I'd encourage you to go through it. We probably won't have time to do it all on this call, but there's been a blowing up in the chat while you were speaking. People are really impressed with this work, and I have a lot of other questions. So the transcript will be on the website. If you have a chance to run through that and follow up with some folks. But we were introduced to the folks at Integral Care through Rebecca Farley and Chuck Ngoli. Rebecca, actually, I understand you're going to make a few comments from National Council. When you all think of CCBHC and what its crisis components might do, this is pretty exciting, right?
It's so exciting. And I have to say, this is my second day in a row of attending a presentation with Integral Care, and I learned something new, and I'm blown away again every time. To me, one of the most amazing pieces they have put in place is all of this incredible data collection around their impact, because we know that lots of organizations are out there doing similar work, but the ability to quantify it, to express, the percent reduction in involvement with law enforcement, to talk about, you didn't really talk too much about the cost savings, Marisa, but, to talk about the associated costs that are saved to communities and states as a result, is just an amazing tool in winning support for initiatives like this. So I'm so proud to get to work with Integral Care and to see the amazing work that you all are doing, and and work to share how the CCBHC model can help other organizations do similar activities. But I think Chuck is on the line too. I'd love to hear from him if he has reactions, as well.
Yeah, let's go back one slide. Chuck, this number of 82% diverted, and then go back again, Karen, to the pie chart. And then Marissa's comments about most of those aren't getting the EM cot. Most of those are getting some kind of follow-up and support. This is a tremendous finding for our 988 coordination. Chuck, what are you thinking as you hear all of this?
Well, just so excited to celebrate and to broadcast what Integral Care is doing. And, we always get to learn something, right, from the pioneers, and how do we spread that? And certainly, David, it goes back to some of the comments that you made earlier, right? How do we have adequate capacity in communities to be able to do this? And, that's one of the reasons we've invested so much time and energy over the years in trying to build nationwide expectations and capacity through CCBHC. So just look forward to, figuring out how we can continue to do that going forward.
Well, and Chuck, so our theme today has been this step-by-step. Certainly National Council's leadership with CCBHC goes back many years of building on that foundation. I'm wondering if John Franklin Sierra or Captain Gannon from LA County are with us. You all have done a lot of work in this 911 and mental health coordination. John, are you with us today?
I'm here, yeah, and I don't have much to add other than this is really impressive. And I mean, you all seem even further along than we are in the integration of 911 and mobile crisis response. And it's great to see a lot of synergy between the direction you've gone and the direction we're trying to go in LA County. And feels like we're kind of in sync, and also something for us to aspire to, especially in the comment about data. I think it's really commendable, like the way that you've tracked all of this and quantified these outcomes, and definitely something we aspire to do too.
Marisa, final comment from you. So John and the LA County folks, they have 80 separate PSAPs because of the cities in LA, and then they have 20 specialty. For cities like Atlanta or Austin or Houston that have a large 911, but still there are many other 911s. What are your thoughts about what are your thoughts about how to keep going with this, given the many 911s we have out there?
I mean, to kind of replicate this type of project in other cities, is that what you're?
Yeah, so just to give an example, in Atlanta, there's a Fulton County major and a city of Atlanta 911, but there are probably 15 to 20 other 911s and at least 160 911s across the state because every county has one. So this heavy integration as not, there will likely right now, the Lifeline has 160, 180 call centers, and there are thousands of 911 centers. So it's just how do we take this to the next level given the limited staffing and such?
That's a really good question. I feel very fortunate to be here in Travis County and have it all kind of located. And I know that that poses some challenges with other parts of the nation that are experiencing that. And so I would say just kind of looking at the structure that you have in place right now, I can let you know that just to kind of move forward, what was the most helpful was just building the relationships and trust with the community partners and stakeholders within our community, figuring out what is going to work best in their system, coming together, bringing in our area of expertise as well, establishing those memorandums of understanding and really getting champions to kind of move this forward. For us, it was our council who really championed this to kind of get us in. It's long been a goal for our agency to get integrated into our 911 call center. So the champions, building the relationships, and then looking at what services you do have and what options you do have to help kind of get the most efficient system that will work for your community, I think is what I can offer without, just generally.
Yeah, that's great. Well, congratulations. Terrific work. And we'll look forward to updates as you continue to take these steps forward. Thanks everybody for joining, and look forward to seeing you next week. Dr. Eric Raflawan will be our guest speaker. Thank you. Thank you, Marisa.
Thank you.